So I've revised my searches this year to make sure that we include anything relating to the assurance framework, and I've updated the enhanced services. I've also added a sort of month which is all our patients. The idea is you can then see why it is we split them into month of birth so that we don't have to invite 1,000 people in one month. We're inviting them in right about 100 a month for the routine tests, and then generally each month there's about 100 people who need inviting for our enhanced service processes, and then another 100 who sit outside enhanced service and sit outside routine but need calling in when their processes are due. So this might be high risk medications or very abnormal results or following up for initiation medications, etc. The full list of criteria and processes is in some of the other videos. And most of these are fairly self-explanatory. So the audit for DOAC at the end of the year is in here with those that have been on it for 12 months and those who are newly initiated and that sort of thing. And similar for gender dysphoria, the prescribing enhanced service for this year, MGUS searches and shared care. This assurance framework I want to look at today. So I'm sure you've all seen the paperwork for the framework. Now what I've been looking at are the areas that I think are indicators that relate to clinical work we do day in, day out. So practices will have to do their own toolkits and show that they're compliant with national alerts and all that sort of thing. But say, for example, prescribing safety module 1.3, I have made a search to try and show that within EMIS. And what's fortunate is that this is very similar to the quality improvement project we did a few years ago, and looks likely to be the quality improvement project we're going to be asked to focus on again in the coming year. Now, we do have these searches in Audit Plus. I just like seeing them in EMIS. I also think that the prescribing safety tab in the primary care information portal is a slightly more useful, friendly place to see how you are compared to national averages. So if we go to the portal and we go to prescribing safety in the portal, it has the various prescribing indicators in here. And there's a few different ways of looking through this information. I think it defaults to your health board, so I tend to feel it's useful to choose your own surgery. You can, so each of the indicators are PS and then a number. So if I go back to my searches here, the PS01 is those over 65 with anti-inflammatories and aspirin and clopidogrel with no gas protection. And I can see I do have patients in that search. And if I open up PS01, you can compare yourself with All Wales and Health Board and Cluster. So for example, the blue line here is me, where it's telling me I had 2 patients in this numerator, but the average is obviously lower. So we were slightly high for that one. And you can do this for each prescribing indicator and see them at a sort of careful breakdown. So PSO2 would be things like, let me go down. So there's patients aged over 65 with antipsychotics, and you can see that we're below average there. And I think it's useful if you want to look at each indicator in turn. The organisation comparison shows you them all in one page. This goes from, the first one's at AF, ignore that for now, but PSO1 all the way up to PS30. And when you go to the paperwork for the unified contract, what you see is that the first element of prescribing safety is the first bunch of them there, and then you've got another bunch of them further down, which is the (2.3). set of indicators, the timely monitoring of high-risk medication. So again, it does tell you it's in Audit Plus and in the Primary Care Information Portal, and that's in the same place. That's in prescribing safety. So that's the ones that are numbered, I think, 16 onwards. So patient with a prescription methotrexate and a high liver function. And the idea is the purple line is my practice, and the little blue columns are my practice, and it gives you an idea of where you are compared to the national average. For example, here you'd say the current prescription of azathioprine with no LFTs in the previous 3 months, PS23. You'd argue mine was quite high compared to the average. If I go to the searches we made, so 2.3 here, and I look at azathioprine, no LFTs past 3 months, yes, I have got 10 patients, which seems a little high at the moment. So 1.3 and 2.3 are all in the same place inside the Primary Care Information Portal prescribing safety tab, and I've built searches so you can see them inside your EMIS as well, so you can pull the patients up. 3.1 in the assurance framework is the stop a stroke. Now, what we're looking for here is people without prescription whose risk, that's CHA2DS2-VASc risk, is greater than 2. So you're looking for people with AF whose stroke risk is raised but aren't anticoagulated. And again, this is in the Primary Care Information Portal. Now, I know the contract says to look at atrial fibrillation and stop a stroke. But if I go back to my searches, I think the easiest place to see this data is in chronic conditions in the AF tab. So if you go to Primary Care Information Portal, chronic conditions AF tab. So I'll go home in this one here. And if I go down to chronic conditions and I go into the AF tab, atrial fibrillation tab, and practice view, and what I want to see is the measure, which is the fourth or fifth one down, no prescription but high risk. And then this, if you click filter on there, it'll tell you we compare with the rest of the country. You want to be low on this one, so we've got 10 patients identified here out of 167, so 6%, which is close to the national average, slightly lower than local average. And it seems that different indicators will have different weighting, so they're going to be more bothered by some indicators if you're well outside the average and in the bottom 10% or higher 10%. So for this one, if you had a high number of patients with AF who weren't anticoagulated, then I suspect you may well be asked to look at how you might improve that. And again, I've made searches inside EMIS, and this is also partly based on some of the quality improvement work we did in the past. So again, if I've got a patient who doesn't have anticoagulation, whose risk is over 2, and it tells me I've got 9 here, I can tell if they've been declined in the past or stopped. But I've got a couple here where we've not declined them or ticked not indicated or any of that sort of thing in the past. If I open one of those, you'll see that we display a text saying, hey, there's an assurance framework concern, AF but not anticoagulated. And that will also show in the alerts box as assurance concern, AF not anticoagulated. I have to hide the box because it's got a patient name on it and you can't see that. So you can't see the hovering that tells me that it's AF not anticoagulated and it's an assurance framework monitoring issue. If you were to double click on that, this would open the chronic disease template. So these are the sorts of templates where we pull everything to one place. So it highlights that this patient should be on a statin but isn't. Advice on heart failure management with links to heart failure care plan and NICE management, pointing out that we don't have an echo coded, that this patient doesn't have an ACE but they've got heart failure, diabetes and heart failure, should consider FLOSIN, they're on the AF register. We're still using the CHA2DS2-VASc calculator, but we do have to advise that it's off-label and you need to use clinical judgment if you're going to use that. And then pointing out that they're AF not anticoagulated. for all our patients with AF, even if they're not anticoagulated, I still leave the DOAC review box in, partly just so that if you are thinking of prescribing a DOAC, you've got things like the Cockcroft Galt calculator, which again is off-label use of EMIS calculators. So again, you'd have to decide whether you want to use that or put in the parameters online. And just the little boxes for the review there. It's got the orbit scores for people to score for themselves. I know that this patient has a high orbit score because it's suggesting that they probably do, and it'll say okay that there's an HB concern. So for women, you score 2 if their HB is under 120, and this lady's HB is 100. You score 1 if their EGFR is under 60, which means that they now have a 3 orbit score, and another 1 because they're over 74, so their orbit score is 4, which is probably why they're not anticoagulated. And I think there's also boxes about appropriate CKD coding, pointing out that this person's for variable kidney failure risk is likely greater than 5. Advice on what to manage with CKD high-risk patients, although I think this patient is already under the renal team. And then the diabetic reviews, this poor thing, again pointing out raised ACR but no ACE, ACR between 3 and 30, no FLOSIN. We need to make sure we give driving advice for the glycoside if they're driving, and the rest of the review. Now, I appreciate that was probably quite a complex patient with lots going on, but it also shows the power of the template being able to pull in everything into one place. And I think it's quite convenient to have most of these things there. You might not do everything, although you might, and bring somebody back for other elements, but depending on how you want to work these things. Clearly, there are lots of reasons why that lady may not be anticoagulated. Now, the next part of the assurance framework is, well, the next clinical part is some of the work around diabetes. So 3.2 asks for the practice percentage of PR01. So that's the 8 measures recorded. Low is bad, so you want to have most of your patients having had their 8 core processes monitored. So again, we've built searches here for this in 3.2, and this search here shows PR01 and then the 8 processes below. So the idea of this will show you how many patients have had each in the last year, and mine sits at about 54%. Now, to see the national averages on this one, again, the portal's a good place to go, and I think for this one it's the portal, chronic disease, diabetes, and the NDA Practice Support Monthly. I'll show that. So for this one, we're going to go chronic conditions, diabetes, and then NDA Practice Support Monthly. So at this point, we're looking to see the 8 processes. So if you go down almost straight away, it shows you care processes across Wales. So this is the Wales tab. So if we look here, this is the Wales tab, and it's showing that roughly 40% of patients in Wales have had their 8 processes monitored. And then these are this is the percentage of 7 measured, so if 22 plus 42, so 63 have had 7 and more, another 10%, so 73 have had 6 and more, and it gradually goes down. The one on the left then is each process, so this is predictably lower, which is the purple NDA09 is all of them. Urinary ACR is the one where only about 58% of our patients have had that done. So you need to then go up and choose your own practice, which for me is quite a glim. And this is where we see an amusing upswing. So when the assurance framework came out in October, we realised that we had very, very low 8 processes, and very early identified that we weren't routinely measuring smoking. I think there's a misunderstanding around not having to ask if they've said never smoked several times in the past. We weren't as good at weighing as we would like to be. Foot checks were a bit down. But the worst was ACR. We were not routinely doing ACRs. I think this was partly a misunderstanding over some of the inactivated QOF in the past. And we went away, had a chat with our nurses, and we suddenly started doing all these processes and catching up, and we've pulled our 8 process by the end of March up to 53%, which is higher than the average of 42% in Wales, so we should be okay. One of the searches I have put in here is a little search on which patients to chase. So if we know that we had quite a high percentage of our patients who'd had 7 processes done, so they'd done everything, but they hadn't had one process, which was for us mostly ACRs. And we, back in October, had a large number of people where they'd had 7 processes done, but not ACRs. So we organised to get some urines off 80, 90 of them, and Bob's your uncle, it pulled us back up to 8. So it's quite nice to see where you are and see which patients perhaps to chase if you wanted to bring your figures up quickly. And it's useful to see perhaps which processes you may be missing for whatever reason in your practice. The next framework indicator is one I don't like enormously, which is TT07, all treatment targets met. So again, that's in the same place. So it's in the same page of the portal. And if you go down, and here it's got the treatment target. So TT07 is those patients who have managed to get a cholesterol under 4 and a blood pressure under 140/80 and an HbA1c of under 48. So my TT07 figure is at about 14-15%, which feels low, and then we go to the Wales national average, and we can see it is a little low because the TT07 figure in Wales is about 22%. So that's one where I don't know whether we'll be in the bottom 10% or not for that one. I suspect probably not, because it's quite an aggressive target, that one. So we've made searches for that too. So again, we've made searches looking for TT01, which is HbA1c under 48, TT02 under 58, which perhaps is where we're mostly targeting, if I'm honest, most of the time. And then TT03 under 86, blood pressure under 140/80, cholesterol under 4, cholesterol under 5. But of course, if you want to hit all 7, then you are having to get the very low targets here. Now, the next part of the assurance framework goes back into medications. So if I go back to the assurance framework paperwork, you can see that the next part, so that was diabetes, 3.4 is opioid burden, 3.5 gabapentin pregabalin, 3.6 is antimicrobials, and 3.7 is the 4 Cs. And so we've built searches for these two and advice on where to get your current data. So opioids, yes, you can make a nice sheet. The prescribing enhanced service in the BETSI is also looking at this, so this is handy for both. And you can open that up. It's got patient identifiable information, highlight the patients perhaps on highest opioids. I know we're particularly focused on daily amounts over 120 milligram. At the moment, and I'll show this, there's no data either through Spira or Primary Care Portal on opioids. I don't know about the Audit Plus. Now, the information for the prescribing, I think the most useful place for that is Spira. So if I go perhaps as an example, if I show you the gabapentin search, so here we've just got our patients on various strengths of gabapentin and then a breakdown for an Excel sheet if you want it. I can't show that here, it's patient identifiable. But there is, if you right click on the search, it's got the link to take you to the right place. So I'll open that up. And I'll just go into the, and it takes us to the Spira homepage, and then the one we want to look for is the National Prescribing Indicators. Now the screen doesn't fit well to my laptop, but I'll try and get the data up. This is national data, and what you can't see just above where we're having to cut off is tabs that you can look at your health board, you can look at your cluster, you can look at your practice. So for the gabapentin pregabalins, we've got this tab here, and this would be the national trends for gabapentin and pregabalin. What you can do is explore by practice, and this will show you all the practices in Wales. And so at the moment it's defaulting to W00065 in Conwy, but I'll go. I shouldn't show somebody else's, but it's you can see everybody's practice on here. So 94029, which is mine, and you're probably all familiar with these Spark charts. I've got to try and scroll slightly to the right here. There's two things the Spira thing has on here. So it's so you can show the Spark charts that show you roughly where you're up to. Blue is good, orange is less good, but generally going in the right direction, hopefully for most of ours. What you mainly want to know for your assurance framework is, are you an outlier? Are you likely to be in the bottom 10% or top 10%? So if you were 4C items, then you might not want to be towards the top here. And if you were antibiotics, you don't want to be up here, you want to be down here. Let you see who's the best. And you can do the same for your gabapentins, pregabalins. I guess for the purposes of assurance framework, it's going to be looking to see, are you an outlier? Clearly there's enhanced services for prescribing, looking at some of these issues as well. I have made searches for these, and I guess we should try to look at some of these. But so you might look at your pregabalins and gabapentins. I think it's pretty useful to look at the highest dose patients first. Same for gabapentin. We've done searches for antibiotics. Some of these are quite nice, so you can see what you're giving your antibiotics for. So for this one, we're antibiotics for various, if there is a linked code, it'll show it. And we can also look to see who is the highest prescribing of antibiotics, which in my practice, it looks like it's me. I guess when you find that you are the highest prescriber, one of the things you could look at is, how does that compare depending on numbers of patients seen or clinical contacts or session numbers? So there's also a numbers for consultations. This is a simplified thing, just showing GP, telephone, home visits, etc. But I guess you could use that if you wanted to really try and identify, are you a particular outlier looking at antibiotics against number of clinical contacts. It just means a bit of playing with the data. There's a few things, people who are having 6 or more antibiotics a year, so you might want to see, well, who are they and why, and then people on repeat antibiotics that have an antisplenectomy, and the same searches for the 4 Cs as well. And the information for all this is in the Spira National Prescribing Indicators that we looked at before. So it's in the same place, antibacterials, and you can see that we're going the right way for antibacterials and going the right way for 4C, and we're middle of the road where we are. And you can do the same thing for 4C prescribers to see who are the people giving more of the 4Cs than the rest of us. Again, it's me, but you might want to look at consultations in order to try and balance out prescribing rate. And I think it's useful to look at patients who've had more than one 4C antibiotics in a year and repeat 4C antibiotics. The last search here relates to prevalence, which I think is one of these things that mentions in the contract further down, which is just 5.1 disease prevalence rates. So it's looking to see, are you particularly low prevalence, are you an outlier? I have done a search for this, but again, I think the portal's better for that. So chronic conditions and disease prevalence. So if you go into the portal and you go down for where was this? Chronic diseases, chronic conditions, and disease prevalence. And I suppose what we want to try and see is are we particularly low in any of these? And I think the useful one is probably organisation comparison. So this is where you might look at, again, the purple line is your trend. My practice is green. And you want to look to see are you particularly out on any of these ones, to see is there any particular area that we should be looking at. I can't see any obvious areas, although I think sometimes we're in light blue. I think obesity, perhaps we were low, although we're picking that back up again now. And I think otherwise maybe we've got slightly higher amount of learning disabilities. We have higher number of osteoporosis than average. So I think it's just a thing to look to see, are you particularly an outlier for anything there? Now we're told we'll get our report for us, and I don't know which of these has the highest weighting. But what I have done is pulled all of these into my normal templates and recalls and searches from these up above there, and save for the enhanced services for the year.